Welcome to The Explainer. If you're a pathology trainee, you know that signing out a melanoma excision is a big deal. It's one of the most high-stakes reports you'll ever write. So today, we're going to demystify the College of American Pathologists, or CAP, protocol for invasive melanoma. Think of this as your roadmap to creating a report that's clear, accurate, and absolutely vital for patient care. Okay, so here's the game plan. We're going to start with the why this structured reporting is so incredibly important. Then we'll walk through the whole evaluation step by step, measuring the primary tumor, checking for spread, figuring out the lymph nodes, and finally pulling it all together for that final PTNM stage. First things first, so why all the fuss? Why are we so rigid about following this protocol? Well, because it's way more than just a checklist for accreditation. It is the absolute foundation of patient care. It guarantees that every single clinician, from the surgeon to the oncologist, is on the exact same page. Now, the whole system is built around this concept called synoptic reporting. And yeah, it's a non-negotiable for lab accreditation. But look at the format. Instead of some long, dense paragraph, you get this super clean, structured list. Every key finding is paired right next to its answer. It just kills ambiguity and makes the vital info pop right off the page. The rules here are really simple, but they're so powerful. You know, each data point gets its own line, which makes the report instantly scannable. And while you can tweak the order a bit, all the required stuff has to be in one spot. This means the entire clinical team and, just as importantly, the cancer registries can find what they need in seconds. Okay, now we're getting to the real heart of the matter, the primary tumor assessment. These are the measurements that are going to form the absolute backbone of your T category staging. This is where it all begins. Now, this is a huge deal, especially for trainees. For decades, we talked about Breslow thickness and Clark level almost in the same breath, but that's changed. The focus now is crystal clear. Breslow thickness, that measurement in millimeters, is the single most important factor for the PT category. Clark level, it's now optional. It's nice to know, but it does not drive the stage anymore. Next up, ulceration. Listen, this isn't just any old break in the skin. The definition is super specific. A full thickness defect in the epidermis with reactive changes. The most critical thing to remember is that it has to be tumorigenic ulceration, caused by the tumor, not just damage from a previous biopsy. If true ulceration is there, it's a big deal. It automatically upstages the tumor, bumping a PT2A to a PT2B, for example. Another massive prognostic factor is the mitotic rate. So what you do is you find the dermal hotspot, that's the area with the most action, and you count the mitoses in 1 square millimeter. But here's a huge update from the AJCC 8th edition that you absolutely have to know. The mitotic rate is no longer a criterion for T1 staging. It's still a powerful predictor of how the patient will do, and you must report it, but it doesn't define the T1 stage anymore. This picture is a fantastic illustration of the body's immune response. We're looking for what are called tumor-infiltrating lymphocytes, or TILs. When the protocol says a brisk response, it means one of the two patterns you see here. Either the lymphocytes are all over the base of the tumor, or they're right inside the tumor itself, fighting it out. Seeing this is actually a good thing. It means the patient's immune system is putting up a fight. Okay, so we've got the primary tumor measured and characterized. But what's it doing? Is it just sitting there, or is it trying to spread? Now we're going to look at the features that tell us about its behavior. The word microsatellite has a very, very specific definition. It's a tiny nest of melanoma that's completely separate from the main tumor, with normal tissue sitting in between. And here's a little pearl for you when you're at the scope. You have to look at multiple levels to be sure it's really a separate focus and not just a weird tangential cut of the main tumor. So this brings us to a really critical and maybe kind of a counterintuitive point in staging. Here's the question. If you find a microsatellite in the skin, how in the world does that affect the node category, especially if the lymph nodes are totally clean? Well, the answer is a real game changer. Just finding microsatellites by themselves automatically kicks the patient up to at least an N1C stage. That tells you just how serious a finding this is. We also keep an eye out for these other high-risk features. Things like lymphovascular invasion, neurotropism, tumor regression, they all give us crucial clues about how aggressive the tumor is. But here's the key thing to remember. While they are all powerful prognostic signs, none of them are actually used to figure out the final T category. All right, Let's talk about the regional lymph nodes. You know, their status is one of the single most powerful predictors of a patient's survival. So getting this part of the report perfect is absolutely essential. So the standard of care here is the sentinel lymph node biopsy. It's designed to find microscopic disease you can't see or feel, what we call clinically occult disease. And the CAP protocol is super clear about this, especially for you trainees, so listen up. Frozen sections are strongly discouraged. Why? Because you can introduce artifacts and you might miss a tiny focus of disease. The standard is permanent sections with your H&E stains and, of course, immunohistochemistry. No, when you do find a positive node, you can't just say, yep, it's positive. You have to report the tumor burden. And this diagram from the protocol, it's your best friend. It shows you exactly how to measure that largest metastatic deposit, whether it's one tiny focus, a big mass, or a bunch of separate nests. That measurement gives the clinical team really vital information. All right, we have gathered all of our data, all the little puzzle pieces. Now it's time for the final synthesis. Let's see how all this information we've gathered under the microscope comes together to build that final, crucial pathologic stage. Honestly, you should just print this table out. It's basically your cheat sheet for the T category. It lays out the only two factors that really matter, basal thickness and ulceration. And your eyes should immediately go to that critical 0.8 millimeter threshold that now helps define T1 melanomas. You have to master the logic in this table. It's fundamental. The N category, I know it can seem complicated, but it really just boils down to answering three questions. First, how many nodes are positive? Second, how'd we find them? Was it clinically occult disease, or was it a lump the patient could feel? And third, are there any of those microsatellites we talked about? The answers to those three questions give you your final N category. So let's do a quick recap of the key updates from the AJCC 8th edition. You have to have these locked in. We've got the new T1 threshold at 0.8 millimeters. Mitotic rate is no longer a T criterion. We use the new terms occult versus detected for nodes, and microsatellites are now officially part of the N category. Getting these details right is what makes your report both compliant and clinically powerful. So at the end of the day, what's the big takeaway? It's this. The CAP protocol is not just some bureaucratic document you have to fill out. It's an essential clinical tool. Think of it as the roadmap, or maybe the translator that lets us turn what we see under the scope into a precise language that directly guides life-saving treatment decisions. And that really brings us to our final thought here. When you think about it, this incredible level of detail, it does so much more than just check a box for accreditation. It creates a common, unambiguous language. It completely transforms collaborative cancer care. Your report doesn't just go to the surgeon. It speaks directly to the medical oncologist, the radiation oncologist, the clinical trial teams, ensuring everyone is united in the fight against this disease.